Vertigo as a symptom are best described as the sensation that you or the environment around you is moving or spinning. You may feel like you're almost drifting to one side, or the room is spinning around about you. You often can't control it. It's such a strong symptom. You often have to holding on to something to stabilize yourself. It's a bit like when you were younger, you went on a fairground ride and you were being spun round, and when you came off, the world is still moving around about you. And that's the sensation you're typically expecting to see in somebody who's complaining of vertigo. It's not that kind of lightheadedness kind of thing. It's that real sense of motion that you almost is out with your control. The symptoms can be quite mild, but also can be so severe that you can almost prevent you from standing up. You have to go and lie down. You can feel quite nauseated, and when very severe, sometimes it can lead you even to have to vomit. Okay, so I mean, vertigo itself is usually caused by issues with the inner ear itself, as described previously, with common balance disorders. It can also be caused by conditions that affect the brain itself, including migraines or strokes. Obviously, the latter is uncommon, but severe vertigo often will lead for somebody to be acutely assessed at an emergency department, particularly if the GP is concerned regarding the severity of the vertigo. In reality, with clinical assessment, you can generally differentiate out a central sort of stroke cause of feeling very vertiginous versus a peripheral or inner ear type problem. But that's not something you'll be able to assess yourself at home. The other thing, of course, is it's very different from other causes of imbalance, notably, as I said earlier, when you're lightheaded, often when standing, and that's more usually due to blood pressure control, and very different from vertigo. And it's obviously very important to separate out that sense of vertigo from non-inner ear type issues, as well as deciding whether or not your symptoms are so severe that you merit urgent assessment to rule out a more serious or worrying central event. Obviously, if it's relatively mild and you feel otherwise well in yourself, you're usually okay. Most of these things will self-settle. However, if it is a very severe new onset symptom, and you're not feeling well, the problems I described earlier is that, okay, it may well be a peripheral problem, but you don't know if it's not a central problem. And that's one of the things that always causes anxiety within the health professionals ourselves. We don't want to miss anything more severe. So in somebody who's got inexplicable severe vertigo, we'd normally advocate that they speak to the emergency services and decide the best way forward. Often that involves going to A&E or accident emergency to be assessed and make sure there's no other evidence that could point to more serious underlying pathology that could be detrimental to your health. If you are having chronic events and you've been assessed, it is worth speaking to your doctor, because usually the common cause of the more persistent chronic events are the positional one we discussed earlier, the loose crystals, the BPPV, and that's easily diagnosed and easily rectified. The other conditions we discussed regarding inner ear causes of vertigo or even with migraine, they often can be clarified from the history and appropriate treatment can be started. Clearly, if that's proving ineffective, then it is important to see a specialist to assess the symptoms, establish a diagnosis, arrange appropriate imaging if felt necessary. But once that clear decision is made regarding most likely diagnosis, then really what we're looking for is a targeted management protocol to try and improve your symptoms, settle your symptoms, and return you to normal health once more. In reality, the decision regarding the best fit diagnosis, because sometimes it's sometimes been quite difficult to differentiate one from the other. But when you're looking to try and get that diagnosis, you're getting a lot of it actually from the history. So a very careful history taking is really important. I often say that to my juniors, that perhaps half your time should be taking a good history as well as examining the patient. It is so key. From the clinical examination itself, there are some things we look at. We specifically focus on what your eyes are doing. We expect them to be stable. If you have a more acute problem, you have a condition called nystagmus, and that's where your eyes will be jerking like that. So you'll be aware of that yourself. The world will be moving like that. And truth be told, that's very rarely seen outside the acute setting, and actually settles in a reasonably short period. So by the time you come to the clinic, we often won't see any evidence of that. But we do still look forward to make sure that your eye movement is normal. We then go on to see if there's any particular evidence of almost like of residual damage in the inner ear, so to speak, by doing a little short head motion test that allows us to see if one of your ears is still, and that's a very key test. That's possibly the most important one regarding vestibular function that we do. We then do some tests of your function, and that's more about getting you to stand up with your eyes closed to make sure you remain stable, and then we get you to do the same but marching the spot, and that's trying to differentiate, to sort of separate out your inner ear from your joint input, from your visual input, and to see, when we take everything else away, how well you can keep stable just using your inner ear function alone. The last thing we do in everyone is that position test called a Hall pipes, which is where we lie you down with your head to the side. And in that, we're looking to make sure you have no loose debris inside your inner ear, that BPPV condition, which is so common. That's important because A, it might be the diagnosis that needs treated, but B, if there are other problems that have that as a secondary problem, you can't actually treat the initial issue without getting rid of the BPPV first. Because a lot of the exercises make you better can't be done if you have BPPV. Beyond the basic tests that we think of as the bedside tests, there are other things we wish to do. We perhaps want to arrange a hearing test to see if there's any evidence of any unilateral hearing loss or one-sided hearing loss that can be seen with labyrinthitis, or with somebody who's had a Meniere's event or something like that. And if possible, when available, we can actually use some objective tests that look at inner ear function. If you have a acute vertigo, so you're feeling that eyes moving, quite nauseated, the acute phase is treated with what we think of as labyrinthine sedatives. That's a tablet like Stemitol, prochlorperazine. These are very strong tablets, and they'll settle down that nausea, and we'll often give them in a way you can take it as a little tablet that melts away in your mouth, because obviously if you are feeling quite nauseated with it and quite sick with it, you may not keep the tablet down and vomit it back up. So that tablet is a very powerful one. The key thing about it that is important to use it only during that sort of acute episode, as if you were to use it in an extended way, it would actually delay recovery, because you're numbing your inner ear functions. You're not getting that vital input that your brain needs to formally recover. So you're delaying your recovery, as well as that, in the worst case scenario, particularly in the elderly population, I've actually seen long-term Stemitol cause imbalance and dizziness in these patients. So it's a very strong drug, very effective, but short-term use. Any treatment beyond this, however, will be very dependent upon the diagnosis. Maybe a simple one-off canal repositioning maneuver, should it be simple BPPV, the debris issue. Extending to prescription of appropriate medication for those with something that needs treatment, such as migraine or Meniere's. Overall, however, in those who've had severe vertiginous episodes and are starting to recover, there are things that can be done to hasten and improve recovery for these patients. These are usually through targeted vestibular exercises. They can be the ones that you may have heard of, where you're simply just sitting in a chair looking at a distance, or looking at this, looking up, looking down, look at Daroff exercises. But these days we're moving towards more aggressive rehabilitation, where you're looking at a fixed target, such as your thumb, and moving your head side to side and up and down quite briskly. And that sort of stimulates the brain to listen to the information it's getting from the ears, that even when you've recovered, there'll always be a mismatch. Your brain needs to learn about that mismatch. So if you can expose it to quite challenging situations, you'll get better quicker. But you can see how if you've got loose debris floating around, that isn't going to be working. That's a bad thing to do. So it's important just to make sure that you're the appropriate person who will benefit from that rehabilitation. When these exercises are performed appropriately, you do speed recovery and you get yourself back to satisfactory function in as short as time as possible.